So we wrapped up atrial dysrhythmias last week. We ended with atrial flutter. Let's start now with ventricular dysrhythmias. There are three major ones. Let's look at the first one, PVCs. So if you read PVCs, these are similar to PACs. So we discuss PACs as generally harmless, especially if they occur in a patient with otherwise no significant cardiac history. Just like PACs, PVCs are caused by excessive intake of caffeine, smoking, or excessive alcohol. In some patients, especially those admitted with cardiac problems, they are considered serious. Let's say patients came in with a diagnosis of acute coronary syndrome, meaning heart attack or cardiac ischemia. PVCs may result. Think of PVCs as irritation of the cardiac cells, usually caused by ischemia. What is ischemia again? Ms. Botina? Decreased oxygen supply to one or more parts of the muscle, of the organ. Other causes are dystoxicity, hypoxia, acidosis, etc. Now, if a PVC occurs, there are usually patterns to it. PVCs can be classified as bigeminy if it's occurring every other beat. First, let's look at what a PVC looks like. You know what a QRS looks like, right? Okay, so a PVC is a distorted QRS. So in this figure, you see a normal QRS here. This is a PVC. It's obviously distorted, doesn't look anything like a normal QRS complex. Here's a normal QRS complex, normal, normal, a PVC, a PVC. If a patient's PVCs are the same, if they all look the same like these, all throughout the patient's rhythm, then we call it a unifocal PVC. That means it's the same source that is causing the PVC, meaning the same part of the ventricles are firing these premature electrical impulses. You follow? If, however, it contains another type of PVC, so this one is another PVC. It looks nothing like the other premature beats. This one is as distorted as these, but they obviously don't look the same, do they? So if a patient has different appearing PVCs, then we call it multifocal. Really depends on what is the source of that PVC. One more time, if they look the same, we call it unifocal because they look the same. So the same culprit, same bad guy, same bad part of the ventricle is firing or triggering the premature beat. This one is coming from a totally different source. You follow? Okay, so there are different patterns here, and then I'll ask you questions to see if you can have a try at what type. If you look at figure A, so you have a normal PVC here, followed by a distorted one, right? Normal and then another distorted one. So the pattern is every other, correct? You have a sinus and then a PVC, sinus, PVC. So that's what we call a bigeminy because it's every other beat. What if it's every third beat? Meaning you see sinus, sinus. When I say sinus, that means normal, okay? So let's say sinus, sinus, PVC, sinus, sinus, PVC. So it's every third beat, correct? What do we call that pattern? A trigeminy. What if it's every fourth beat? Sinus, 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 PVC, sinus, 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 PVC. What do we call it? A quadrigeminy, okay, and so on. Now, we typically don't see a quintugeminy or whatever you call every 5 beats. So we stop typically at every fourth. Now, however, PVCs can also occur in succession, meaning how many PVCs do you get when they appear? If there are two in a row, we call it a couplet, a couple. There's three in a row, we call it triplet. What if we see four in a row? Quadruplet. What if we see five in a row? In that case, it's either quintuplet or we start actually calling them VTAC, ventricular tachycardia. Okay, we'll get to ventricular tachycardia next. Let's finish PVCs. As I already mentioned, PVCs depends. Is it occurring in a patient who is otherwise normal with no significant cardiac history? Then generally they're harmless. However, if it's occurring in a patient with either a significant cardiac history or let's say they're admitted for a cardiac problem, such as let's say a likely heart attack, PVCs are serious. In fact, we consider them a warning sign that another serious dysrhythmia is about to come. So always think of PVCs like PACs. All they are irritable signs of the ventricles because they are PVCs. So in PACs, there were also irritated cells in the atria. These are again the common causes. So just add their excessive intake of caffeine, nicotine, or alcohol, or these conditions here: heart failure, tachycardia, DIGE toxicity, hypoxia, acidosis. So these are the common triggers for PVCs. The decision whether or not to treat them really depends. Is the patient symptomatic or not? Or what is the patient's underlying condition? So let's say the patient's admitted for a suspected heart attack and we see PVCs. Should we treat it? What do you think? We better treat it. Okay, so have your shot at this. So what would you call the figure A? What type of PVC? Is it unifocal or multifocal? The first one. Do the PVCs look different? Does this PVC look different? Okay, they're the same, so it's unifocal. As far as the pattern, is it bigeminy, trigeminy, quadrigeminy? Bigeminy. Okay, very good. Is it well, it doesn't fall under couplets because there's only one, right? One at a time. Okay, let's go to figure B. What is the type of PVC as far as, is it unifocal or multifocal? Multi, more than one source, because there's more than one type. Is it, this one has different patterns. So the first pattern between this one and this one, what do you call it? This would be bigeminy, every other beat, right? However, for us to call it bigeminy, there has to be more than just one. Okay, so this one won't really qualify as a bigeminy. How about this one now? 1, 2, 3. Okay, if there was only one, we call it trigeminy. However, again, we can't call it a trigeminy because there are two in a row. So this one will just be called couplet. Okay, so this, as you can see, can you estimate the heart rate in this particular pattern of rhythm? Okay, we can still estimate it, but will it still likely be the same from 1 minute to the next minute? No, highly irregular. So the rate would range here between, I'll just estimate, okay? So these are your 3-second markers. So we got 6 seconds here. So we estimate about 1, 2, 3, 4. So it's about 80 something. But from this minute to the next minute, we don't know if the rate will stay within 80. All right. Management. Depends again, if the patient is symptomatic and what is the primary condition for which they are admitted. If they are frequent and persistent, what's the treatment? Amiodarone or beta blockers. But what did we learn last week? We looked at the table with the antidysrhythmic drugs. What should we always keep in mind whenever we administer antidysrhythmic drugs? Okay, they will trigger new and even different dysrhythmias. Any questions on PVCs? All right, so let's go to BTAC now. So if you remember from your latest BLS, so when was your last BLS class? Last year or 2 years ago? Okay, for some last year, some 2 years ago already. So you're up for renewal then. Okay, soon. Okay, so BTAC is 3 or more PVCs in a row. So we usually cause VTAC at around 5. Okay, so in practice, we start calling it a VTAC when we see 5 PVCs in a row or more. Those 5 PVCs don't really equate to seconds because as you can see, is it really, when look at this PVC here, is that really equivalent to seconds? Because how many seconds is, how many big blocks are there in 1 second? In 1 second?
0.2.
No, how many big blocks in 1 second? If one big block is 0.2. It's 5, right? Yeah, so every 5 big blocks is 1 second. So is this really 2 seconds? Not at all, right? So when we say if there are, so imagine that there are 5 PVCs in a row. Is that really 5 seconds? No, only 1.5 seconds, right? Okay, so therefore, if the patient experiences that type of that duration of VTAC, does the patient even feel it? No, because it's so short, right? So it's common to see, let's say, if I have 10 VTAC beats, 10 beats of VTAC, 10 of these, how long would that approximately be? So if let's say one PVC is about 1.5, right? 1.5 big blocks. So if I get 10 of them, how many is that? How many seconds is that approximately? About 3 seconds, right? 3.5 seconds. So are patients even aware? Okay, so most patients will not experience any symptoms, right? So it's common to see, let's say in my unit, my telemetry tech calls me, hey, your patient just had a 10-beat episode. So what's the first thing I do again? Okay, I always look at the patient. So I go to the patient. Most of the time, they're either sleeping or let's say watching TV or eating or brushing their teeth. Most do not have symptoms. But do I stop there? What will be my next assessment? Okay, I'm obligated to look at vital signs to see what impact did that episode have on the patient's blood pressure. Is the patient symptomatic? Okay, and every episode, of course, that's serious because VTAC, what are the 2 shockable rhythms again? And VFib. Okay, so was it serious? Yes, ventricular tachycardia are serious rhythms. However, it's also important to note that there are 2 types of VTAC. There's a VTAC with a pulse and a pulseless VTAC. Which one is worse? Obviously, the pulseless VTAC, which is treated by what? Defibrillation. Okay. If the patient has a pulse, that means, do they have a blood pressure? Yes. Okay. So for those patients, the treatment would be, let's go straight to treatment. You have the option to do, well, not really your option. The doctor will give you the order. So here are some of the choices the doctor can choose from. So amiodarone, procainamide, sotalol, lidocaine. Or if the patient has symptoms, then the doctor may opt for cardioversion. Again, these are not our decisions, okay? The doctor will decide how to treat the VTAC. Again, depending on whether it's a VTAC with a pulse or a pulseless VTAC. So therefore, if let's say Ms. Duff is our patient and she's on a cardiac monitor, so you saw from the nurse station she's in VTAC. What do I do first again? Okay, so I go look at Stephanie, and then what do I do next? I see her. Let's say she's sleeping. What do I do next? I see, oh, she's asleep. Okay, I better not wake her up. What do I do? Do I do that? So what do I do? Considering there are two types of VTAC. So VTAC with a pulse or a pulseless VTAC. So I will go and check her pulse. Okay, so I'll check first. Which pulse do I use? Pedal, posterior tibialis? What's the easiest pulse to take? I'll check her carotid. Okay, so I'll go check her neck. Does she have a pulse? She has a pulse, then I try to wake her up, okay, if possible, and then check her vital signs. And then I know how to proceed. So I'll notify the physician, and then he'll give me an order, if anything, right? So what if I come in, Stephanie has no pulse? What's my next action? Is it rapid response?
Yeah.
BLS, what do you do with BLS? What was, so hey, so if it was in a grocery store, what do you do? Find the patient pulseless? What? Yeah, so I did that. Okay, so Stephanie's not responding. So what do I do next? Clock out? Huh? Do I go with chest compressions? What did you do first? I did that. That's why I saw it's a pulseless VTAC. So what's my next action? BLS. Do you have a defibrillator in your pocket? Did you bring it in when you went into the room? Do I start compressions?
Yeah.
How long will I do compressions if I do that right away? I'm going to be there all day. So what do I do first? I'm already in the hospital. We are 911. Okay, that's where patients end up in. So you're in the hospital. Is it a rapid response or is it a code? Rapid response is not the same as a code. Okay, rapid response. Yeah, the doctors will come in. Will they expect a pulseless, unresponsive patient in rapid response? Not necessarily, but if you call a code, what do they expect to find? What is CAT in your facility? I'm not sure because every hospital is different. So what is your code? Cardiac arrest code. What is it in your code blue in your facility? What about for others? Okay, you have CAT. That's your code. Who else? Who else has a different? Like mine is weird. Ours is 101C. It's different for every facility. Anyway, that's what you do first. Okay, so just like if you were in a supermarket, what do you do first? After saying, hey, you okay? And then no pulse, call 911. Hey, you call 911. Okay, somebody 911. And then you do chest compressions. Are we clear? All right. So do I leave the room and get the defibrillator? No, you stay there. So after shouting, activating the code, begin chest compressions. And as soon as available, the AED or the defibrillator, shock the patient if indicated. Are we clear? All right, so that's how we handle VTAC. So pulseless VTAC. What about VTAC with a pulse? What's your first action? Okay, check on the patient, check for a pulse. Okay, if there is a pulse, what do you do next? Okay, vital signs. Well, you do rapid response, right? So call rapid response, and then you proceed with vital signs while waiting. All right. Okay. So this is what VTAC looks like. Whether there's a pulse or not, they look the same. We'll discuss ICD and everything later. It's on the next page. VFib. So this is the sister of VTach. What does it look like? That's VFib. Nothing else looks like it. Totally disorganized, no pattern whatsoever. So is it different from a pulseless VTach? Okay, exactly the same. After you establish unresponsiveness, pulselessness, then you call a code, then begin chest compressions and defibrillate as soon as able. Next, asystole. So this is very short since there is no electrical activity here whatsoever. So patients in flat line, so straight line. You may see a few bumps here and there, but that doesn't make it not asystole. It's still called asystole. So what's the only treatment here? Only chest compressions. Can we defibrillate? Why not? Is there a rhythm to defibrillate? No. So the only treatment is chest compressions. Okay. So let's review. So that's why it's called asystole. Is there electrical activity? No, that's why it's isoelectric. That's why it's flat. So why is the treatment only chest compressions? To generate an electrical impulse. Okay, so you begin chest compressions. So by compressing the heart, then you will get blood flowing. And then once blood is flowing, what happens to the electrolytes that is circulating? Are they going in and out of the cardiac cells now?
Yeah.
Okay, so is that generating electrical activity? Yes, so the first rhythm that comes back after asystole is usually VFib or VTach. Then you can defibrillate the patient. Until then, provide good quality chest compressions. Okay, patient's life depends on it. So as soon as you do proper chest compressions, show me again your chest compressions. Miss Russell, show me again. Is it really like this? No, your elbows are not supposed to bend, right? It's supposed to be straight, right? And then your whole body doing the chest compressions, all right? Okay, you're reminding me of my college days. My friend we were in the ER, and then we received the patient in cardiac arrest, and then we continued chest compressions. And my classmate was on the stretcher, literally riding on the stretcher, and he was doing this with a grin on his face, right? Am I doing this right? And the patient obviously didn't survive. I'm not saying he did it, but patient had a Foley, and we were doing post-mortem care. And first semester, no idea what keeps the Foley in there, so he just yanked it. It came out, the balloon came out, and it's like, oh. Good thing the patient was dead. Regarding codes, please always be aware of what your patient's code status is, okay? Because we don't want to get sued for a missed opportunity. Remember, these patients are DNR for a reason, right? Why did they choose to be DNR? Because, hey, they want to see their maker, all right? They don't want any, and you don't want to deprive them of that. Once you initiate CPR, can you just stop it? Once you find out, oops, DNR, better stop this. No, it's too late. You already started it. So the key is not to have done it in the first place, okay? So make sure you're aware of who the DNRs are. Don't waste resources because again, well, we don't call a code. You can call the resident to come see the patient before it happens. Or if it already happened, yes, you still notify your physician, but there's really no heroics, right? There's no interventions to be done. Well, yes and no, because yeah, if that's your patient, or if let's say you're covering for somebody because that person gave report to you. But what if you just came in because you heard a sound? So let's say right before it happened, they knocked their pitcher down. So you responded to a sound, you had no idea who this patient is. Right? So let's say it's a big unit. Let's say mine, we have 26 patients on the unit. We have 26 beds. I don't know all 26, right? So I'm only concerned, or I'm at least knowledgeable about the 4 that I have. Make sense?
Yeah.
Okay. Unless I get report. So it's important to listen to huddles. Okay, we usually have a huddle during report. Don't ignore that because you listen to code status, so at least you're familiar with who's a DNR, right? Because there's no such thing as, oh, that's not my patient. Are we clear? Right? Because it's really literally everybody's patient if you're on the floor. Do you understand that? Any questions on the 3 ventricular dysrhythmias? Okay, let's proceed with conduction abnormalities. When we say conduction abnormalities, there's a block in the transmission of the electrical impulse. What we're talking about is the impulse coming from the SA node to the AV node and then to the left and right bundle fibers or bundle of His and all the way to the Purkinje fibers. So there's a block somewhere there, okay, between the conduction, somewhere along the conduction pathway. Let's start with the 1st degree heart block. My teacher in college taught this in a way of a relationship, and it has stuck with me until today. I never forget the heart blocks because that's how I looked at it. So 1st degree heart block. First of all, this is not really a block. Rather, this is a delay. So in a relationship, let's say me and Miss Figueroa, for instance. So let's say we're steady. Okay, so we're boyfriend, girlfriend. And we usually spend dinners together. Not some fancy restaurant, just dinner, let's say at a taco stand or at home, for instance. Okay. So in 1st degree heart block, this is what it looks like. The only thing wrong here is the PR interval. If you measure the PR interval, is it 3 to 5 small boxes? Begin here and it stops here. Is it between 3 to 5? It starts here and ends here. This is the Q wave. So that's the PR interval. Measures from here to here. Is that between 3 and 5? Miss Carla? 0.12 to 0.2. So is it big or small? Small, right? 0.12 to 0.2 seconds. So is it between 3 and 5 small boxes? From here to here. This is the Q wave. Remember we measure it from where it leaves the isoelectric line to where it returns. So it's measured from here to here. Is that between 3 and 5 small boxes? How many is it? Is it between 3 and 5? This is 5 alone. From here to here, it's already 5. It starts here. So is this between 3 and 5?
No, it's more than that.
It's more than 5 now. So is this normal PR interval? Let's look at another one. Pick any PR interval. Look at this one. Between here to here. Is that between 3 and 5 small boxes?
No.
So as you can see, all the PR intervals are longer than 0.2 seconds. So that's the only thing wrong in 1st degree heart block. Sometimes it will lower the heart rate down to below 60, but sometimes it's exactly 60. Okay, depending on how long is the PR interval. So sometimes it's 0.22, sometimes it's 0.24. seconds. So obviously if it's 0.24, then that will drop your heart rate to below 60. You agree? Okay. So what do we do if we see, let's look at the causes first. So what can cause the first degree heart block? The causes are mentioned here. So it's either these drugs, because the patient's taking calcium or the beta blockers, or taking digoxin, an negative inotropic drug, Lyme disease, MI, heart attack, hypothyroidism, or let's say giving birth to a big turd, for instance, vasovagal response, or vomiting. Okay, so these are other causes. Coughing. So if you look at these, what do they look similar to from last week? Bradycardia, right? So similar causes of bradycardia can potentially cause first degree heart block. Now let's go now to what do we do? Our signs and symptoms. Signs and symptoms, generally none. It is very rare that a first degree heart block patient shows symptoms at all. Typically none. So therefore, do they require treatment? No symptoms, no treatment, right? So therefore, what can I do? What am I obligated to do? Identify and eliminate, if possible, the underlying cause. If the underlying cause are beta blockers, or what is the potential treatment? Patients given any of these drugs, do they need these drugs? They don't need it. So why are they taking it? Because they wanted to. Okay, so they needed these drugs, right? So obviously, what will be done if it's causing heart blocks now? What do you think the doctor will do? Scalu? Maybe, but remember, they need it. Can we change the dose maybe? Okay, so yeah, so the doctor may, you may expect the doctor to either decrease the rate or maybe, as Ms. Carlos suggested, maybe hold 1 or 2 doses and see what happens, right? Okay, so that's basically the treatment for first degree heart blocks. Nothing serious. Okay, it's very rare that first degree heart blocks cause any symptoms, if at all. Let's go now to second degree. Second degree has 2 types, second degree type 1 or second degree type 2. So what does a second degree type 1 look like? Like this. So in same relationship, so me and Milagros are dating. Okay. So in first degree, our relationship was, we're still on, but then do I arrive on time on our dinner appointments? No, I'm always late, right? That was in first degree. Now, as our relationship went to second degree type 1, what happens is, yes, I'm late. Okay, I arrived late. Let's say Monday, I arrived late. Tuesday, even later. Wednesday, even later. And Thursday, do I show up on Thursday? No, I stand her up on Thursday. See, this P wave here has no QRS. You noted that? Here, yes, prolonged PR interval that's longer than 5 big small blocks. And there's a QRS here. Long, even longer. Okay, this one went from 0.20, 0.22 to now 0.24. Okay, right here, about 24 or 26, and even longer here. And then no more, I didn't show up. Right? So does Milagros like that? No. Does this patient typically cause symptoms? Sometimes, yes, depending really on the heart rate. Here, we have 3-second markers here. 3-second marker, 3-second marker. So we assume the 3-second marker is there, right there. So what's the heart rate here? The ventricular heart rate in this rhythm. 1, 2, 3. It's missing 4. So what's the heart rate? in the 40s, right? So depending really, because some second degree type 1s have a heart rate of in the 40s, sometimes it's in the 50s. It really depends on how long the PR interval is. So the decision whether or not to treat depends on whether or not this patient has symptoms. So asymptomatic second degree type 1, do we necessarily treat? No. So same thing as first degree heart block, depends. Okay, so let's look at the underlying possible causes, try to modify or eliminate them, and then see what happens. Let's go now to second degree type 2. Now, if you look at the second degree type 2 in this figure, unlike type 1, wherein what happened to the PR interval in second degree type 1? It got longer, longer, and longer, and then got dropped, right? So here, is there the same is that the same pattern? No, it's not. The PR interval remains the same. So let's look at this patient's PR interval. So here to here to here, it's long, right? But it's not getting longer. It's consistently long. However, is there only one or a few blocked QRSs, or is the patient now having multiple missing QRS? So this P wave has one. This P wave, does it have a QRS? Nothing. It's a block here. P, QRS, P, another block, P, QRS, T, P, block again. So this patient has multiple missing QRS complexes. So therefore, is this worse than type 1 or just the same as type 1? This is now worse. So the patient's heart rate here, let's estimate again. This is our 6-second strip. It's our third 3-second marker is somewhere here. What's the heart rate here? The ventricular heart rate. 1, 2, 3. Also in the 40s. All right. So do we need to treat this one now? Yes. Second degree type 2 definitely requires treatment because this will produce symptoms now. Let's look at the treatment. Symptoms again, it'll be the same as anyone with low cardiac output. So in second degree type 2, what do we do? What's the first aid? Like what will be the likely first treatment? Because the patient will require a pacemaker. However, before a pacemaker, what will the doctor try first? So look at the drug chart from last week. Atropine. Okay, so atropine 0.5, first dose. We can repeat that in about 3 to 5 minutes later. If the patient doesn't respond, you can try a second dose. Still none, patient will require a pacemaker. We'll discuss pacemaker on the next page. Let's finish third degree heart block. In third degree, this is what it looks like. Here's third degree. Let's look at the P waves here. Start with this one. P wave. That's it. Yeah, it's not as easy. Let's start here. P to P. P to P. And we don't have a P there. But we have 2 P's here. Okay, so P to P, okay, occurring about the same time, right? And we don't have a P there, but we have one here. So as you can see, are the P waves occurring regularly? The P to P, is that regular? Same interval, right? This is an exception, but P of that P to that P, is that regular? Yes. Same distance as the first two. Again, same, right? So therefore, since they're P waves, Is the SA node firing?
Yes.
Yes, it is. And last week, we learned that the AV node, is that a pacemaker also?
Yes.
Yes, it's a secondary, right? And while the SA node fires 60 to 100, how many is the AV node capable of firing? 40 to 60. So let's see if and what's the evidence of a ventricular contraction? The QRS. Okay, so let's look at the QRS, the R wave. So this R wave and that R wave. Are they occurring regularly? But is there a P wave before every QRS? PQRST, PQRST, P, there's nothing here. Okay, occurred later. P, QRST, PQRST, PQRST. That one didn't have a P. So therefore, what can you say about mine and Miss Figueroa's relationship here? Are we talking to each other? No more. Since you can see the P waves are occurring regularly here and here, they're occurring regularly, so therefore, is the SA node firing? Yes, but is the AV node receiving each one? Not at all. As you can see, the evidence is there's a different atrial rate. There's also a different ventricular rate. Both are regular. So regular atrial rate, there's also a regular ventricular rate. So therefore, are we talking to each other? I'm the SA node, she's the AV node. Are we talking to each other? No. So this is what we call a complete heart block. So third degree heart blocks are complete heart blocks. Is that clear? Okay. So definitely, since the SA node and the AV node are firing, why is the AV node firing its own impulse? Because it's not receiving any from the SA node. But does the SA node know that? No. The SA node's firing. So they're like, hey, the AV node's going, hey, I don't know what you're doing, but I'm not getting any impulses. So I'm going to generate my own. Okay. Then the SA node will also say, well, I don't know what's going on down there, but I am firing 60 to 100 times per minute. I don't know what's going on. So somewhere in the middle, somewhere between the SA node and the AV node pathway, something is blocking the transmission. Yes.
So because the AV node is secondary piece, so it's just like.
It's firing, but it's not capable of firing 60 to 100. It'll fire, but only 40 to 60. Yeah, because is 40 to 60 compatible with life? Can that sustain? Let's say you're running around or you're under stress. Can that sustain life? No. So it's not enough to sustain life. So this patient needs a pacemaker, right? So there's nothing we can fix. We can't put an artificial electrical conduction pathway. It's not possible. We don't have that technology yet. So until then, patients like these will require a permanent pacemaker. All right. So let's go now to the pacemaker therapy, which is, I'll come back to cardioversion. Let's go here first. Okay, pacemaker, and then I'll backtrack. So Mr. Gersten, can you read what is a pacemaker?
Pacemaker is
Okay, thank you. All right. So since it's now taking over the pacing, correct? So the device is now firing the impulses. So on the ECG, what you'll be seeing, are we expecting to see a P wave here? No more P wave because the pacemaker is firing the electrical impulses. So in the first picture, you have A and B. In A, do you see P waves here? None whatsoever. What you see in place of the P wave, these are QRS complexes. What you see in place is a pacemaker spike. So in figure A, this is what we call an atrial paced rhythm. So the atria are paced by the pacemaker. Instead of the SA node firing, it is now the pacemaker firing, and then the AV node gets it and then transmits it, showing us the QRS, then cycle goes on. In figure B, it's obviously not, this is lead 2, this is not lead 2. I'd say this is about maybe ABL maybe, you know, that part. So instead of the QRS complex, what do you see? The same pacemaker spike. So if that's what you see instead of the QRS complex, now we call it ventricular pace. Okay, so ventricular pace, V pace, V pace, V pace. Okay, so no more SA node, no QRS complex. Depends. What is being paced? Is it the atria or the ventricles? Okay, really depends on what is the patient's underlying problem. So there are two types of pacemakers. We have permanent or temporary. Why is there a temporary and a permanent? The patients who require immediate pacemaker therapy, so let's say the third-degree heart block occurs right now. Okay, so let's say Miss May Jean has a third-degree heart block today. We gave her up to 3 doses of atropine, no luck. Heart rate remains in the 30s. So we applied a pacemaker. The temporary pacemaker comes in 2 forms. So it's either transcutaneous, meaning over the skin, or transvenous, wherein the device is outside her body. However, the wires are inside her heart. Let's look at the first transcutaneous type first. So the equipment used there is the same defibrillator we use for cardioversion and for defibrillation. Same LifePak defibrillator. Same pads we use as if we were defibrillating her. Okay, so we put pads on her chest, and then we, instead of turning it on to defibrillation or cardioversion though, or turning on the synchronized button, we turn it on to pacemaker. So we switch it over to pacemaker. So what the machine will do is it will fire tiny electrical impulses across the pads, through the pads, across her skin and into her heart. Voila, we have a temporary pacemaker. So that can stay on for a few hours, for maybe 8 hours, until the next morning. At the next business hour, the cardiologist, the cardiothoracic surgeon comes in and puts in a permanent pacemaker in her. Does that make sense? So there's no such thing as an emergency that they'll call at 1 o'clock in the morning, that they'll call the cardiothoracic surgeon for a pacemaker insertion. Hey, there's no such thing. It can wait because we have a temporary pacemaker. Does that make sense? Okay. So anybody who needs it will get it instantaneously right now, but not permanent, obviously. Okay. Now, the second type is still temporary. We call it transvenous. Now, that type, show you the picture. This is not this, because this is now the permanent pacemaker. So in permanent pacemaker, this is the pacemaker inside the patient's body underneath the skin, and then the wires are threaded into the heart, into the atria and the ventricles. Now, in a transvenous, that pacemaker remains outside. Bigger though, not as small as that. It's a bigger device. However, the wires are inside. Now, when would they use this type as opposed to the transcutaneous? Obviously, can we use the transcutaneous for more than a few hours? Will that be comfortable? Having something sending electrical shocks through your skin? Not comfortable, right? So that would be someone who needs a pacemaker for a long time, but for some reason, we cannot put in a permanent one yet. That reason is usually when the patient has some infection. So let's say they came in with sepsis, but they require a pacemaker. So what will happen if the patient has an active blood infection and then we put a foreign object like a pacemaker inside? What will happen? Yes, Putina? No, go ahead. So what will happen? You have a blood infection. Okay, there's bacteria in your blood. And then a doctor puts in a permanent pacemaker in your body or an ICD, whatever, or it could be a catheter, a central line, a Foley. What will happen to those devices since they're foreign bodies? They're going to get infected. Okay, because will the body protect a pacemaker, an ICD, a Foley catheter, a central line? Will your body protect those things? No, because they are foreign bodies. The body could care less. Okay, they'll just say, oh, somebody reports, oh, hey, there's an infection in that pacemaker that they put in. So what will the immune system say? Who cares? That's not one of us. Okay, that's a foreign object. Let them grow there. So that's what's going to happen. So bacteria will make house out of that foreign object. Okay, so do we want that? No. So in the meantime, the patient will receive a transvenous. The device is outside. However, the wires are inside. Will the electrodes get infected? No. Well, it's inside. Will they get infected? Absolutely. Okay, but it's okay. It's not staying there permanently anyway. We're taking that out. All right. So we'll just wait until the infection clears. Patient now finish the course of antibiotics and then they're infection free. We'll take it out. Then we'll put in the permanent pacemaker. Does that make sense? All right. So that's usually the scenario why someone would require a transvenous. So call it like a bridge, a bridge between the permanent and the temporary. Let's talk about the settings now. There are two general settings on a pacemaker. So it's either set to on demand or fixed. When we say on demand, the SA node is still firing. It's still functioning, it's firing. However, is it likely to perform its job consistently? No. So in that case, the doctor will set the patient's pacemaker at on-demand setting. This means the threshold usually is 70, which means if the patient's SA node fires less than 70 beats per minute, meaning 70 electrical impulses per minute, the pacemaker will kick in only during those times. So if the patient's intrinsic rate or the SA node falls below 70, the pacemaker turns on, starts firing. Does that make sense? Okay. On fixed or asynchronous, this setting overrides whatever the patient's SA node is doing, meaning the SA node becomes useless because now the pacemaker is in charge. It will fire whether or not the SA node is firing. You follow? Okay, so these are the two different settings on a pacemaker. So you either set it on demand or set it fixed or asynchronous. We'll look at our responsibilities and patient teaching on the next page because it's not, maybe it's on toward the end of this page. Two charts here. First chart is chart 22-7. These are the complications of after a pacemaker is inserted. I'll leave you responsible for reading. They range from local infections to the bleeding and also a pneumothorax. What else is mentioned here? Cardiac perforation, tamponade. All right, so a few complications related to the insertion and the device. The other chart, it's not this table. You can disregard this table because we're not responsible for this anyway. It's the doctor that's responsible for this table. All right. For the patient teaching, you can either do all the paragraphs because there's mention of the discussion on the paragraphs, or you can go to, but for my exam, I can either grab it from the paragraphs or from the chart. Okay, so I'll go to the chart because it's shorter. It's on the next page. Okay, it's this chart. Chart 22-9. You'll notice that the title of the chart is Implantable Cardiac Device. Again, chart 22-9. This is educating the patient with an implantable cardiac device. It doesn't say implantable cardioverter, which is the title of this page. Here it says implantable cardioverter defibrillator, which is referring to an ICD, which is going to be like a miniaturized defibrillator. This chart 22-9 therefore refers to both an ICD, the cardioverter, the implantable cardioverter, and the pacemaker. Do you understand? Because are both implantable cardiac devices? Yes, the patient can either have a pacemaker and or an ICD, but teaching is the same. They're under chart 22-9. You understand? Again, don't disregard the paragraphs because the discussion is in the paragraphs. So let's start. These patients are on cardiac medication, so they're still on their calcium channel blockers, beta blockers, digoxin if indicated, ACE inhibitors, their diuretics. Because are these patients basically in heart failure? Yes, caused by electrical conduction problems. So they have heart failure. Okay, let's start with this first. So what symptoms have to be reported? So patients with pacemakers or ICDs, they are told to check their pulse daily, count their pulse daily, and then report the following. Okay, so they report these symptoms, these changes immediately. Avoid infection. So how do they avoid infection? There's a little error here because these bullets should be indented because these following these 3 bullets here actually refer, no, 4 bullets, 1, 2, 3, 4, actually refer to the avoiding infection. And then you'll see this on the previous page under the pacemaker, under the title of preventing infection. So if it's newly inserted, let's say, because they're not kept in the hospital for a long time. After pacemaker insertion, they're kept maybe 1 to 2 days and they're sent home. So the incision is still fresh. They have either staples there or stitches. So leave it uncovered, then check daily for redness, increased swelling, and heat. And report if the patient has any fever. No spandex. So Miss Mira, I know you like wearing tight spandex, so not yet. Okay. You wear tight spandex? Oh no, okay. No tub baths, okay? So they can't soak their body, not the incision site for a while. And as far as the activity, here are the activity restrictions. Can't raise their arm above their head, so therefore, can they drive or operate machinery? No. No heavy lifting for a few weeks. The limit usually is 5 pounds. Okay, so anything over 5 pounds, no lifting. So here, driving again, typically, plus don't worry, I mean, these patients are not in any mood to be driving. Okay, so they're weak. Okay, they have fatigue. But if there's nobody else to drive, some of them may be tempted to drive, but typically no. The restrictions is about the same, about 2 weeks, no driving, consistent with the arm activity restrictions. So this one may take up to 2 to 3 weeks to resume normal activities. Is sexual activity normal activity? It's not normal? It's, I mean, is it normal activity? Or do I need to take Viagra or extra vitamins and Red Bull in order to perform sexual activity? Not typically, right? So it's normal activity. So this will follow the same. Okay, so 2 to 3 weeks before resuming normal activity. Except contact sports, of course. You don't want anyone, period, okay? You don't want anyone hitting your ICD or your pacemaker, all right? Electromagnetic interference. Now, it's important to understand what equipment emits heavy EM fields, electromagnetic fields, okay? Obviously, MRI, large speakers. So if you ever go to a concert, don't be in the front row, okay? Because those large speakers have large magnets. Welding equipment, they're actually mentioned here. So large motors, arc welding. So large motors include aircrafts, right? Airplanes, those GE engines, are those large motors? Yes. What about microwave ovens? Can they use them?
Yes.
What does this say? Yes. Household appliances, including microwave ovens, should not cause any concern. Now, for those who may be wary about microwave ovens because you've seen signs around, those are old signs. So let's say you've probably seen those signs in HHC facilities like Bellevue. You see those signs, right? Every now and then, some doors have, some walls have microwave in use, you know, let's say pacemaker, something like that. That's like in the 1930s, 1940s. Those signs are that old. Modern microwaves after World War II are now safe. Okay? Especially the microwaves today, they're all digital. They're not using the old technology anymore. So they're safe. Okay? We can use pacemaker, and ICD patients can use microwave ovens. All right? And most office equipment too, like copiers, they're fine. Cell phones. Cell phones and other electrical devices emit some electromagnetic fields. That includes all equipment that transmit radio signals, radio frequency signals. The instruction is not to place it within 6 inches of the ICD or pacemaker. So if I have a cell phone, how should I hold the cell phone? I have to make a call. Okay, either speaker, or where do I hold it? Let's say I'm in a public place, no? Too noisy to put anything on speaker. I have an ICD or pacemaker here. Okay, make sure you hold it on the other arm. Okay, that's 6 inches, right? Okay, so that's good. TSA security devices. So those things that they have a wand, right? They have handheld, and they also have that big one wherein you take off your shoes and put your arms over your head. It tells you here that if you go through airport security, you should show them your device information, because you're usually given an ID or a card to show the TSA officers. So ask to be violated manually. All right, right here. So here, show ID and request a hand violation. You know what I mean, right? I mean, these guys violate us, right? Okay, so ask for a hand search instead of a electronic, or the electronic, because those magnets are way too big. With regards to electromagnetic fields, it's not like it'll destroy the device. It's more like it will interfere. All right. But if, let's say, it's welding, here, magnetic fields may deactivate the device. They serve to turn off the device. So if we need to turn off the pacemaker, we usually use a magnet. Okay, so the ER physician has it. So we'll put a magnet over the device and it'll turn it off, so that it'll deactivate it. For other equipment, they may interfere, such as cell phones. They will interfere with the normal function of the equipment. Same thing if you work in telemetry and people have cell phones, right? And whenever I see artifacts, the different waves and complexes on the monitor, it's usually a cell phone. Patient has a cell phone on their chest. So if I go to the room, there it is. Please, and I tell them, please put your cell phone a few inches away from the box, because if it's in the box, it'll interfere with the transmission. All right. More teachings. So tell them to record if they have any symptoms, record them. Daily logs on, let's say, especially if it fires. If it fires, then no, sorry. Firing is under ICD. Okay, so let's discuss ICDs really quick. It's short. So, Mr. Mario, can you read who gets ICDs? It's quite a long list. It's several sentences here in this paragraph. So this is in your exam 3 blueprint. So indications on who gets ICDs. So we already discussed who gets pacemakers, who gets ICDs, and what are ICDs. Thank you, sir. Okay, so this will detect and treat VTAC and VFib. Okay. Syncope. Very good.
Patient with coronary artery disease for 40 days post-acute MI with moderate to severe LV dysfunction. Ejection fraction less than or equal to 35%, or at risk of sudden cardiac death, and therefore ICD is indicated. Call a primary prevention. An ICD implantation is also recommended in patients who have been diagnosed with not actually
Non-ischemic.
ischemic dilated cardiomyopathy for at least 9 months and have functional NYHA class 2 or 3 heart failure.
Okay, thank you. All right, so those are the indications and they're very specific. They are according to New York Heart Association. Let's go look at what does dilated cardiomyopathy look like. So if your heart looks like this, the one on the right, that is dilated cardiomyopathy. Now, do you think this, if your heart looks like this, that it will be able to function properly? Can it meet oxygen demand? Can it sustain ADLs? Or can you walk around with this type of heart? Can you go to the bathroom, take a shower, drive, climb stairs? No, look at the chamber. Okay, so big. Look at the walls of the ventricles. You think this is strong enough to pump any blood at all? No, plus add to that the preload, right? This patient will have increased preload, so much volume to pump with very thin walls. So can this heart function? No, this patient needs a new heart. Okay, they need a heart transplant. So they're basically class 3 or class 4 heart failure patients. So they need ICDs. So other indications as listed here, those who survived, meaning you had a cardiac arrest, so we performed chest compressions on you, somehow we got you back, they will be recommended to have an ICD. Because if they survived, if they sustained and survived VFib or VTAC, can they have another one in the future? And will they be in the hospital during that time? Probably not. Okay, they'll be out somewhere partying or wherever that next episode may be. Patients who have a heart attack, but if they suffered a heart attack and survived, they can't have the ICD until how long? 40 days after. We have to wait until the full healing process has occurred, meaning, yes, part of your heart died. We have to wait until those necrotic tissue turn into scar tissue first, meaning full remodeling has already occurred before we can put in a ICD. Okay. So these are the various indications of who will get an ICD. Now, let me clarify that. They will be recommended to have an ICD. Some patients will outright just refuse and then just accept their fate. They say, no need. Okay, I'm ready. Okay, they'll say, oh, I'm DNR. I'm ready to go. Okay, so next time they have VFib or VTAC, they're ready to go meet their maker. All right. But some are not ready. So they will say, okay, yes, give me an ICD. All right. Now, what are you looking at here? Remember the bridge we talked about earlier, the transvenous pacemaker? Why did the patients have a transvenous instead? What's a likely scenario? They have an infection wherein we cannot put in a permanent pacemaker yet, right? So this is the equivalent for the ICD. So the ICD looks like a pacemaker. It's still implanted inside the patient's skin. And then the wires the electrodes are inside the patient's heart. So this is the equivalent. So patients who have an infection, we cannot put in a permanent ICD, implanted ICD yet, but they need one. So this is the external one. So it's literally a vest made of canvas, cloth. It has Velcro straps. And these are the electrodes, which will detect the VTAC for VFib rhythm. And this is the battery that will power the device in case it needs to deliver electric shocks. So they wear this over their skin and then put the clothing over it. You cannot put a shirt on and then this over the shirt. It won't work. So this one must contact with the skin directly and then put clothing on. Is this nice to wear? Let's say you're in Florida. Have you ever been in Florida? You know the weather there, the climate? Okay. Let's say you're Floridian and then you're told, okay, put this on 24/7. Actually 23 because they're allowed to take it off during a shower. But pretty much it's on 23 hours a day. So do we have good compliance with this? When I had I did side hustle for home health. So patients who have these, I visit the home, they're not wearing it. So I ask, where is it? Oh, it's somewhere there. It's in the laundry or under a pile of magazines or newspapers. Some of them that can't even locate it. I don't know where it is. So you can understand why they don't comply. So that's this brand is Life Best, made by Zoll. Let's finish our teaching, chart 22-9. Here, it says here about do not scare. Here, avoid frightening family or friends with unexpected shocks from an ICD, which will not harm them. Yes, they'll feel the electric shock, but I mean, it's a small device, right? It's not going to have the same number of joules as a defibrillator, which has a larger battery pack. This one is a small device, so therefore smaller magnet, smaller battery, smaller electrical voltage. So especially important to warn sexual partners because this may discourage the sexual partner. I don't want to get shocked because could they develop VTAC or VFib during sexual activity? Yes, because the heart rate is fast during that activity. So it can trigger VTAC and therefore may cause the ICD to fire and electrocute. I want to say electrocute, but shock both the patient and the partner because the partner is in contact with the patient. Okay, so just let them reassure them it's a small shock. Okay, it's not like the 110 volts on the outlet. These devices, both the pacemaker and the ICD, are checked at least twice a year, once every 6 months. There are two companies we have here. We have St. Jude and Medtronic. Okay, so I forgot the term during this morning. So Medtronic and St. Jude are the two big providers of ICDs and pacemakers in North America. Okay, so we finished that. Let's review our other treatments. So last week we discussed cardioversion and defibrillation. What's the difference between the two again? Is the equipment different? Same equipment. So what makes one different from the other? Okay, so if you want to use it as a defibrillator, what button must be off? The synchronized button must be off. If you want to use it as a cardioverter, what do? Turn on the synchronized button. So here's the difference really between the two. It's the timing of the electrical shock delivery. When is it delivered in defibrillation? Whenever you press the button. When you press the red shock button, it will deliver the electrical shock. In cardioversion, when you turn on the sync button and then turn on the shock button, when is the shock delivered? The peak of an R wave. So it will take a few seconds as the device synchronizes with the patient's heart rhythm first and then delivers the shock at the peak of an R wave. Here are your duties with defibrillation or cardioversion. I'm sure you're familiar. You're supposed to be familiar with these because you did BLS. Who are up for renewal this year? Okay. And don't forget to yell clear. Until the machine directs you to stop chest compressions must continue. Are we clear with defibrillation? Which one requires sedation? Cardioversion. I mentioned EPS last week under AFib and A-flutter. So which one comes first, the ablation or the EPS? EPS first, we have to find what we would need to destroy or burn. So once we find them, then the cardiac catheter ablation will follow. Again, ablation therapy, cardiac ablation, no, catheter ablation is the destruction of the causative cells. So once we locate and find these are the cells firing the impulses, causing the atrial fibrillation or atrial flutter, then they'll be up for destruction. All right, that's literally the end of this